Hello, and welcome to the webinar. My name is Lily Catalano, and I will be acting as moderator for today's coffee chat on end of life. This session is presented by the National Healthcare for the Homeless Council and was supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services under a National Training and Technical Assistance Cooperative Agreement. This information or content and conclusions are those of the presenters and should not be construed as the official position or policy of, nor should any endorsements be inferred by, HRSA, HHS, or the U.S. government. This session is being recorded. This is a 1-hour session with time for Q&A throughout. Below the presentation slide, there is a chat box for participant responses, questions, and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. If you are having technical issues, you can also contact the Council's office at 615-226-2292 and speak with Caroline. The PowerPoint presentation and recording of this session will be posted on our website, nhchc.org, within 3 business days. I'd like to introduce our panelists for today. Mark Fox, Associate Dean and Director and Professor of Medicine and Pediatrics at Indiana University School of Medicine in South Bend, and Distinguished Adjunct Professor of Theology at the University of Notre Dame, and Annette Mendola, Director of Clinical Ethics at the University of Tennessee Medical Center. An overview of today's discussion. We're going to spend a few minutes finding out more about who's here participating in the audience. We'll go through the learning objectives, then walk through 2 case studies and have time for discussion, spend a little time on advanced directives, and then have more time for questions and answers at the end. We've now got a poll question to put on the screen, and you can actually click onto whichever of these options best describes your professional position. You can see people are already responded. Got a number of healthcare providers, social workers, community support workers, case coordinators, educators. So a really nice mix of disciplines represented in the room today. And let's talk about where you all are practicing. There's another poll question up on your screen where you can click on which of these work environments best describes your situation. Okay, so it looks like a lot at community service agencies and also at community care facilities and or private hospitals or clinics. Okay. And finally, just a sense of the demographics. One more poll to assess audience age. And again, really a nice range of ages represented in the room today. Our learning objectives for the coffee chat today will explore approaches and challenges related to caring for people who are homeless at end of life. We'll engage in discussion about relevant case studies, and we'll highlight strategies and resources for responding to challenging situations. If you have questions or points that you'd like to make throughout the presentation, I'd really like to invite you to use the participant chat. This is meant to be conversational and interactive, so if there's anything you'd like to say or you'd like the presenters to expand on, feel free to use that participant chat to communicate with us. And I'll now turn the microphone over to Mark Fox to talk us through the first case study.
Great. Thank you, Lily, and welcome everyone, and thank you for being with us for this webinar. In preparing this session, we extended an invitation to council members and people who had registered for this webinar to submit cases. And, caring for individuals who are homeless and individuals at the end of life it can be challenging, especially when they're under-resourced, and when you combine those two, I think it tends to magnify some of those challenges. So this is a case that was submitted by someone who registered for this webinar, so I'm not sure if they're on the call right now or not, but we'll go through the details of this case and then really invite you to think through some of the issues that it presents. So Deborah is a 58-year-old Caucasian woman who's anorexic, chronic inebriate with virtually no social support. Her medical diagnoses are not well established due to a lack of follow-up, but notably she's been diagnosed with cirrhosis, esophageal varices, and thrombocytopenia. And there are concerns that she has a cancer somewhere. She has averaged about a dozen emergency room visits or hospitalizations each month, and her behavioral health history includes severe alcohol use disorder, borderline personality disorder, generalized anxiety disorder, and severe depression. Despite the concerns or suspicions of cancer, it's never been fully evaluated because of fragmented care and difficulty with follow-up. So as far as social background, Deborah grew up in foster care and has experienced multiple traumas throughout her life. Housing has been difficult due to numerous evictions. There's suspicion that she has Korsakoff syndrome, which inhibits her ability to follow through and be available when searching for apartments and things. And she's been reluctant to consider assisted living because of loss of income. And conversely, assisted living providers are reluctant to consider her because of her severe alcohol use. About 5 years ago, the focus on her behavioral health needs, particularly alcohol use disorder, and she had successfully remained sober for a period of about 9 months. But during that time, agoraphobia became pronounced, and her recovery was complicated by loneliness, and she decompensated back to severe alcohol use. That led to a series of incidents with her landlord after having been 9 months really with no incidents. She was ultimately evicted, and there were attempts to place her elsewhere over the next several months. But the end result is that she's been homeless in spite of continued interest in housing her. Everyone who's involved in her care really expects that she could pass away at about any time. So medically, socially, all very challenging. And so, I'd like to ask y'all to think about, what's the best kind of care that we can provide for her given these constraints? What additional information do you need? Frankly, not that I have any of it, but maybe someone who submitted the case can chime in if they know more. But what kinds of decisions need to be made? Who ought to be involved in making those decisions? And really, I think what is the best arrangement for care that we can provide for her given her medical condition and challenging circumstances? So we've resigned ourselves to be comfortable with pregnant pauses here while people think about this and type their thoughts. So if we had Alec Trebek to offer the Jeopardy music while y'all are thinking and writing, we would play that now, but instead I'll just hush and let y'all think and type. people are typing right now, so we'll look for those to come in. But I invite Annette, if you have any questions or points you'd like to raise in the silence, please jump in if you want to. So it'd be important to find out if there's anyone close to her or next of kin, or if she has any advanced directives in place. Unfortunately, this isn't my case, so I don't know any of those details. We weren't provided with any information, so I'm presuming that because she grew up in foster care and other things, that that there is no family readily available to speak on her behalf, and I'm presuming that there is no documentation of advanced care planning. So these are my so Jan has chimed in. It's her case. So Jan, if you have any additional information that you can share, but again, I'm operating on the assumption that there is no clearly identified decision maker to speak for her. So I presume from what Jan said that with no social support and that she's not able to plan advanced care, that because of her cognitive impairment that she's not able to engage in meaningfully in advanced care planning. So guardianship is rare. So if guardianship is rare and there's no family or next of kin to speak on her behalf, someone else has identified that really getting a sense of what treatment options and services are most critical at this juncture and trying to define what Deborah would want certainly would be ideal. Medically, I think there are a lot of open questions still as to what her, the extent of her pathology, I guess, given concerns about cancer. And it may be that knowing whether or not she has cancer may not be the most pressing issue at this point. So the suggestion that I would presume some sort of respite care might be ideal.
And this is Annette. I'm kind of picking up on some of the things folks have said, that guardianship seems like it might be a great idea. On the other hand, that can take a long time. Some states, it's very difficult for that to be established. And then in some states, a guardian is likely to simply make the most conservative medical decisions possible, which may or may not be in line with her values. So it's a mixed bag, I think, sometimes. I don't know if that's something that you're thinking as well, Mark, that a guardian might be a good idea, but then again might not.
Right. I think, having lived in two of the reddest of the red states, I know that the default in our areas is, to adopt the most conservative position possible. So,
right. And picking up on what Lois is saying, so important that advanced care planning, when we're doing that properly, is looking not just at which medical decision is next in line, but what's important to the person, what matters most to Deborah, what given what her life is like now, what makes her happiest, what big picture stuff, what makes her happiest, what makes her most afraid, most concerned, things like that. And to that end, she can probably contribute a lot, even if she's not making the best decisions in order to get herself what she wants. But also sometimes, even if there's no guardian or no next of kin, we kind of think of it as mosaic decision-making rather than substituted judgment, where people who know Deborah, that Deborah's willing for us to talk to, may be able to tell us a little bit about her history and her values and what they know about her. So even if we don't have a hard and fast next of kin decision maker, we may have folks who can contribute to understanding who she is and what matters to her most.
Yeah, I think that's a great point of trying to understand kind of her narrative and what matters most to her. You know, in some respects, one of the real tragedies of this, at least the suggestion in the case description, is that her deterioration 5 years ago was attributed to kind of profound agoraphobia and loneliness, complicating her recovery and led to her decompensation. And so, you know, the self-medicating with alcohol for those conditions is kind of an unfortunate but foreseeable outlet, I guess, for treating those symptoms, and but not able to reverse the clock and intervene in a different way at this point. And now cognitively she may have deteriorated to the point that that her ability to articulate her wishes is really constrained.
Mm-hmm. And I'm looking at that combination of agoraphobia and loneliness, and I'm wondering if this may be an obvious point, but I'm wondering if AA, when she was interested in living sober, if AA was a resource that she was interested in, and if a sponsor or someone who was willing to reach out and kind of walk with her was something that was explored. I'm guessing that it was at least explored. I don't know how willing she was to would have been to engage in that support. And obviously, Jan, thank you for sharing this case. This is lots of food for thought here, and a very tragic situation for Deborah. So, just want to thank you for sharing that.
So, given the limitations that Jan has described in terms of you know, her access to assisted living, or her reluctance to move to assisted living, and her current severe alcohol use and other conditions, you know, how can we best care for her? Is there a harm reduction approach that can help? Is there a hospice approach that could help?
Well, and kind of adding to that, I like Jan's point about the need for creative thinking in cases like this, and also the notion of harm reduction, not setting the bar so high that we lose sight of the opportunity to do some good, even if we can't fix the whole problem. And kind of in that spirit, thinking about using motivational interviewing techniques, which certainly isn't going to solve the whole problem and make it all better, but not only can be very compassionate and effective for both the patient or client, but also can kind of help us, the care providers, feel like we're meeting folks where they are instead of standing over to the side and having our goals for them, which may or may not be the same thing as their goals for themselves.
So from the comments, it looks like Lois has access to some resources that potentially would be very helpful in a case like this. Yeah, although the comment is made that, you know, many involved in her care kind of expect her to die at any time, you know, without a clear diagnosis and clear prognosis, access to inpatient hospice can be limited. You know, I think this case raises a number of interesting and important points that have come up in the discussion. I think that our next case will, and the discussion to follow that will kind of amplify some of these. So we might, to make sure that we have time for that, we might want to address some final comments here. So Jan has indicated that inpatient hospice option is the one that might be the most realistic, but we're far from reaching that goal in her present condition. So one issue that can come up is how best to manage, a chronic active alcoholic, in the hospice setting. We don't see it very often in the, inpatient acute hospital setting, but we have alcohol on the formulary, so that we can do that if needed. I'm not aware that dosed alcohol is common in inpatient hospice settings, but so I think we'll take, we'll read a few more comments about this, and then I will turn it over to Annette, who is going to go through a second case with us, and then some discussion following that. So Lois has indicated, bottom line is that the individual needs to agree to a plan and be able to meet the requirements of sites that would admit them, and so that may or may not be possible. There certainly have been limitations in even exploring housing options because of her cognitive impairment. And so I think Jan makes a great point that accepting Deborah where she is and thinking about the programming that can help support her and how we best care for someone with challenging medical and behavioral issues. So the challenge is rethinking how our programming can best meet those needs. So I think we'll kind of bracket this discussion for now, and I will turn it over to Annette and let her steer and lead us through the second case. Thank you all.
All right, thanks everybody. Terrific comments, and I hope that will continue. Don't wait for us to stop talking. So feel free to continue to chime in. Let's talk about this this next case. This is a de-identified case from the inpatient setting. We'll call this gentleman Sam. 54-year-old gentleman who was admitted inpatient due to abdominal pain, and he's got multiple medical problems, most notably stage 4 colon cancer and a mental health diagnosis of schizoaffective disorder. He had been admitted and then discharged, but this particular admission, he was his medical condition had gotten significantly worse, was not ambulating all that well, although he could still ambulate with assistance. At this point, his prognosis is pretty poor, but with colon cancer, it's difficult to say exactly what his life expectancy would be and exactly what his quality of life would be during that time. He's likely in a situation where he's to live weeks to months, but unclear. His social background, he is divorced, he has no children, he has family in the area, but he's estranged from most of them. He does have a sister who has remained involved in his life and frequently calls to check on him and occasionally visits in the hospital. We asked if she would be willing to take care of him in her home, and she was not, and did not want to she did not want to explore that option at all, but she was willing to help with care planning, and she was willing to be involved with making whatever arrangements needed to be made. Sam has been homeless on and off for most of his adult life. He would sometimes stay in a hotel. This was complicated since his diagnosis with colon cancer, because reportedly, at least, when he stays in a hotel, sometimes he has friends who come to visit him, and they use pain medication that he's been prescribed because of his cancer, they would use that recreationally, and then he would have terrible pain that was untreated until he could get more pain medication. His situation was complicated by the fact that he was a registered sex offender, and so placement has been very, very difficult. Many facilities will simply not take a patient with that kind of legal status, and some are not allowed to because of their location. If they're within a certain distance from schools, daycares, churches, etc., they simply cannot accept a patient in that situation. So some questions that are important to think about with any case, but this one in particular, are what are the relevant facts? What stands out as important? And in particular, when I say relevant facts, I want to say it's important to distinguish between the relevant facts and the moral noise, the kinds of facts that capture our attention but don't help us think through what we need to think about next. Are there any facts that are missing? What do we wish we knew, and could we find out? And what could we learn about Sam or Sam's situation that would change our opinion or change our minds about what issues we're working with? I'd like to think about who are all the stakeholders, certainly the patient, of course, but who else, and what is at stake, who is vulnerable, and what are they vulnerable to? What decisions need to be made and who should make them? Is Sam able to make most of the relevant decisions? And what can we do? What are our possible courses of action? And like Mark, I'm comfortable with the silence, and I will not play Jeopardy music either, but looking forward to a robust chat like with our last case. And Mark, of course, please chime in with your thoughts on this situation that that Sam has found himself in.
So as we did with the last one, we may want to go back a slide and so we can look at medical details.
Yeah, great thought. Okay, so great. So things that we would like to know. What are the motel relationships? Where is his medication shared? What do they mean to him? What role do these folks play in his care? So when you say the motel relationships, Jen, I'm thinking you mean like who are these friends? And my understanding of Sam's situation is that he has friends, people that he has known for some time. It seems to me that at least one person was kind of a distant family member, perhaps a cousin, and they spend time together, and they spend time together in the motel, and that's where the medication is shared. That these are people that do mean something to him, and it would be a loss. It would be a social loss if somehow he were completely cut off from him. Yeah, and Nakia, the idea of a facility that can help with people with felony history would be ideal, particularly if they could deal with both medical problems, legal problems, and mental health problems. No such facility exists. Okay, I take it back. There is one facility that I'm aware of that's in our area. It's very difficult for anyone to get into there. That we had him on a waiting list for there, and he was also not real excited about going there because it's out of this area. He wanted to be closer by. Lois, yeah, you're right. That the motel was a place that he would go when he had the money to go, and sort of complicating things is that if he had medication, sometimes being willing to share that medication recreationally is sometimes a ticket off the streets and into a motel, and so it's difficult. It cuts both ways. And yeah, Jen, it is the sex offender piece was a problem, and I think you're right. One question that I had in terms of missing information was, the idea of a sex offender list is the assumption that someone who is on the sex offender list is an active sexual predator and someone that others need to be protected from. But as you're kind of suggesting, that's not always the case. In particular, whether Sam ever was or not is something I couldn't speak to. But as someone who was minimally ambulatory at this stage, I would want to argue that if he was ever a danger to others, that he probably was not a danger to school children in a daycare down the block, for example. Don't get me started. Yeah, and yet that's the reality. Is that this is what we were working with for Sam, and I know it sounds like you've been working with that as well. Would it be possible? I'm so glad you brought that up, Chelsea. Would it be possible to get pardon or clemency? We certainly tried that, and we were told that would not be happening. That he would not be taken off the registry. And yes, eligible for hospice. And so the issue was where can he go for hospice? Because so possibly a motel, perhaps, but then then you have to have folks that are willing to do that. One of the hospice agencies that had tried following him after other admissions were very concerned about following him again because of this history. So they were. I'm not sure that they were willing to follow up with him again, but using that kind of creative thinking Jan was talking about earlier. Okay, so can locked medication dispensing devices be employed? Just so that we're kind of thinking outside the box. And emergency shelters, again, great suggestions. None of ours in the area were willing because of his multiple complicated issues to do that. But yeah, let's be thinking about some of these options. And it's always, one thing I want to say too is that it's always worth asking. Just because we don't think a resource is going to be worth it, or we don't, we don't think a resource is going to pan out, or we don't think that an agency is going to be able to help. It's worth trying. And Jessica, medical respite programs again. No one willing to take him. Yeah, good thought, Lois. The idea that sometimes relationships between people, between care providers, sometimes will be those that kind of extend on to the person needing help. So if care providers can kind of can connect, and also if relationships between the client or patient or the individual needing help, sometimes those relationships between them and others are the ones that are gonna make something that looks impossible break through and happen. Yes, and that's exactly what we did do, is to ask, while he, at a time when we felt like he had good, solid decision-making capacity, we did ask if she would be someone he wanted to make decisions for him, and he was willing for her to appoint her as his healthcare agent. So that was important to do, and so he did have that. Mark, did you have anything you wanted to add as well, or any thoughts about Sam?
Yeah, I think the discussion has raised really all the points that had come to mind for me. I think, the benefit here is that he has at least a clearly identified decision maker, but the challenge of location of care really becomes the dominant focus, I think.
Exactly. Yeah, and Pam, yes, that was the thought is to try to get him placed in a nursing home for end of life care. He qualifies for hospice, and was not considered a candidate for any further treatment for his cancer. So hospice would have been a terrific resource for him, but no nursing home was willing to take him because of his history. Yeah, and I do like that point about end of life planning. That this is something that we need to be thinking about with all adults, even if we don't flesh out a full written, formal, legal living will with every adult on their 18th birthday. Just as Lois says so nicely, beginning the conversations, talking about what matters, thinking about who you would want to make decisions, who has the ability to speak on your behalf, is really something that, as a country, I think we're finally starting to talk a little bit more about. And yes, I do think that in addition to asking questions, other kinds of questions when folks are admitted to emergency shelters and healthcare services, I would actually not be an advocate of completing full, as I say, sort of full legal living will simply because at those moments, simply because it's hard to think through all those issues. But as you're saying, I would be an advocate of people thinking through, beginning to think through those issues and putting some of these things to paper. Yes, I do like that ICE in case of emergency contact. In case of emergency contact may or may not be someone who is sort of well placed to make medical decisions for you, but it's at least a start. It's at least somebody who might. I'm going to ask, are there final comments on the case of Sam before we go moving on to some additional material? Please feel free, by the way, to continue to type your comments into chat while we're talking. But any further comments on Sam or on the case of Deborah? Okay. Well, we'll again feel free to chat those in, and we'll move on from here. When we think about providing really the best end of life care that we can, particularly in the setting of people who are currently experiencing homelessness, we think about additional barriers that many people face. And so, for example, in both of these cases that we saw today, decision-making capacity was impaired, and so while that's certainly not, and these barriers, I should hasten to say, are not intended to be stereotypes, but just things that we need to be on the lookout for, things that are often the case. So decision-making capacity may be diminished. It may wax and wane to an even greater degree than with the rest of the population. Ability to provide medical history may be more limited than with the rest of the population, partly because it's difficult to access paper charts and electronic charts, and there may be even more sources for these than for most people. Certainly an increased risk of morbidity and mortality because of things like poor nutrition, exposure to the elements, substance abuse, mental health issues, inadequate social support, and perhaps most tragically, violence. And we should notice that homelessness exacerbates any kind of mental illness, which again is going to be somewhat more prevalent in this group of folks than in the general population. Other barriers, difficulties with insurance. true for many people, but perhaps even more true for folks who lack a stable home, and all the kinds of difficulties that are associated with not having with moving around a lot. So limited or fractured relationships with families, difficulty coordinating care, having many case managers, and not only difficulty in having medical information in one place, but also if there is an advance directive, or if a person does have an advanced care plan, knowing whether that exists and then finding it, and even revising it when the time comes to do that. So these are all potential barriers. When we look at the literature, the concerns that people who experience chronic homelessness, the concerns that they articulate have things like this. They talk about fearing the loss of dignity at end of life. Many of us do, but I think this is especially a problem in this setting, particularly the indignity that comes together with being labeled or believing that someone believing that they know your story, even if they're just sort of stereotyping. Dying alone, dying without being reconciled with family, or even just dying without having the compassionate presence of another person. One that I had not thought about before doing research on this topic was a fear of disposition of the body. It just had not occurred to me that dying in a public place and not being found, or dying in a public place and having your body just sort of lying there for anyone to look at, is a fear that folks are living with. Being cremated or buried in a mass grave without any kind of separate recognition that you existed, that you were here on this earth, is a fear. Being treated in a culturally inappropriate manner. We see this especially in research on folks who are Native American and also homeless. That these are concerns that they live with. The fear of not being remembered. The fear of dying and having it be as though you never lived is a fear. Medical fears include things like being afraid that doctors are going to try to pull the plug on them, not give them a chance, just kind of dismiss their lives as not worthwhile. A fear, and this is related to end-of-life care and end-of-life planning, is the fear that if a doctor is looking for a surrogate decision maker, that all they're looking for is someone who will authorize termination of life-sustaining treatment. The fear of being experimented on or being a guinea pig is a prevalent fear. General fears of loss of control and privacy, and certainly a fear of inadequate pain management. And these are all things that any of us might be afraid of, but are of special importance when folks have chronic experiences with homelessness. Preferences for surrogates. Research suggests that most people who are homeless would prefer to have a family member make decisions for them rather than a court-appointed guardian or a physician. But those who don't have family or who are not connected to family tend to prefer physician surrogates over a court-appointed guardian. And I think some of that may be that your physician at least knows you as a person, or knows you in some capacity, whereas a court-appointed guardian may not know anything about you. And so providers should seek additional perspectives if they are taking that role on, simply so that they're not tempted to use their own values, as most of us would be. Like to kind of talk about the chats here in the participant chat. Yes, the advanced directives are certainly a good idea. A PDF to your smartphone, if you have a smartphone, is one thing. There are shorter forms. Honoring choices is one. Thank you, Lois. I also want to call your attention to the Self Living Will, which which was also developed in Minnesota and is under resources there. This is a living will that was developed particularly for use with folks who experience chronic homelessness, in that it asks questions in a way that kind of gets at the experiences of many people who have been homeless for a long time. Advanced directives, of course, are those directions for medical care that take effect if a patient loses decision-making capacity. They're sometimes called living wills. They often indicate a surrogate decision maker, and that surrogate decision makers can be patient designated. If a patient doesn't designate one and needs one, usually a physician will be called on to designate one. And a surrogate decision maker is asked to make decisions for the patient based on ideally substituted judgment. What would the patient say about care if they were able to talk to us? If substituted judgment's not something we know enough about, then we sort of downshift into best interests. Well, what would be the best thing, sort of objectively speaking, for someone in this situation? But sometimes if we can't get all the way to substituted judgment, we can use what some have called synthetic judgment, and I alluded to this earlier, or mosaic judgment, where we don't have the person's word for what they would want. We don't have an advance directive, but talking to many people who know a little bit about them, we can kind of get a picture for what their values are, what matters to them, what they likely would say, not because they've said it before, but because we're kind of extrapolating from the things that seem to matter in their life before that.
Annette, can I jump in right there?
Please.
Earlier when I think I referred to that as kind of the narrative about the patient. So, I often will ask family members or whoever knows the patient well just to tell me the story, help me understand who this person is so that they can paint a picture, and by assembling several of those, as Annette said, in a mosaic, to begin to form some understanding of what mattered most to this individual, so that we can try to make decisions that are consistent with what they value and what's important to them. Because ultimately that's our goal, is to demonstrate some fidelity to what matters most to them.
I love the way you put that. Tell me the story. Tell me about this person and who she or he is. It reminds me of a situation we had where we were trying to help somebody who did not have a decision maker or anyone who was really an appropriate decision maker available, but we were able to talk to a neighbor and then also someone from the convenience store where they would go every morning to buy, I think it was cigarettes every morning, who could say just a little bit, and the neighbor could say just a little bit, and it wasn't as good as having a surrogate. It wasn't as good as having a living will, but it was helpful. It helped understand a little more who is this person who is now in our care. So before doing research on this topic, I never really thought about it. Folks who are homeless valuing advance directives. It just didn't seem like something that would be valuable to them. But the research suggests that some people who are homeless very much value the opportunity to complete an advance directive, possibly because things like experiences with end of life and loss of control at end of life, and fragmented care, and often being treated without adequate compassion or dignity. These are all reasons that maybe you'd want the opportunity to put on paper. This is what matters to me. This is what I'm most afraid of. This is what I most want to avoid. Things like that. And I'm going to run through these just a little bit because they will be available, and I know we want to make sure and get through, at least touch on everything. There's some obvious challenges with advance directives and in the setting of homelessness. However, I do think that it's worth the effort of helping people think through what their wishes would be, and it's worth using a guide that it speaks to some of the experiences that they've had. For example, the self. It's just for healthcare planning. It's not about money. It's not about property. And it doesn't even necessarily need to be made into a legal document to be useful, because, as Mark says, it helps us capture that person's narrative. So rather than thinking about things like treatment options, think about treatment outcomes. The question, what is it most important for you to be able to do and experience in order for your life to be worthwhile? Maybe thinking about those questions rather than questions like, well, would you want a feeding tube? Would you want to be on a ventilator? Those questions I think are hard to capture, but what makes your life worthwhile, that's something that we can all kind of speak to.
And Annette, if I can just jump in to highlight some discussion in the participant chat. Jessica had asked whether each state has their own form for advanced directives, and I think it's important to be aware of kind of the structure and content of your state legislation on this, because there are some states that have very particular nuances that can be challenging. So many of the forms that have been referenced, that are pretty generic, can be very helpful in guiding conversations and decision making. But it's important to know if your state has put any particular twist in there.
Excellent point. Yes. Yeah, very much so. And so as you're continuing the chat, I think I'm going to turn things over to Lily. Lily, if you're ready to take the reins.
Thank you, Annette, and thank you, Mark. And thanks everyone for your participation in the discussion. This was really rich, and I think we covered a lot here today. I wanted to point out a couple forthcoming resources that the National Healthcare for the Homeless Council is close to publishing on end-of-life care. We actually have an in-person training coming up at our national conference in Washington, D.C. later this month. There's going to be a half-day learning lab on caring for people experiencing homelessness facing end of life. There's a complimentary adapted clinical guideline that's going to be published later this summer too, and those will both get into more of the clinical side than we've covered today, but will it certainly include some content about advanced care planning and advanced directives, and as well as even models of care and a lot of the broader issues that accompany caring for people who are homeless facing end of life. We have a couple more minutes here, and I want to invite if there are any final questions or comments that anyone would like to make. You're welcome to type them into the participant chat. I'll pause for a second if anyone has anything to share or ask. And there's some discussion in the comments already about the importance of having these conversations early on. I think that's come up throughout the discussion today, is talking about and being clear on what people value and what their wishes are.
Yeah, I would just echo that. We hear a lot about these, advanced directives that come up at the end of life, but ideally we have a better sense of what people want earlier on. So, as attention to advanced care planning, and now that there's some reimbursement that's available for it, that can help. Although it's not the easiest to attain, but it is something that you can get paid for in office visits now too. So.
Thank you. All right, we're at the hour mark, So thank you all for joining the coffee chat on end of life, produced by the National Healthcare for the Homeless Council. This session will be archived on our website, nhchc.org, within 3 business days, and a link of the archived session will also be emailed to registrants once it's posted to our website. At the close of the session, an online survey to evaluate it will automatically open in your web browser. Please complete it so that we're able to improve your webinar experience. And I invite you to visit the NHCHC website to view other upcoming webinars and other educational products. Thank you. This meeting will now be closed.